Thanks very much, Mr. Chair, and welcome, as always, to members of the public. The purpose of this presentation is for me to, as Mel said, cover the state of the landscape for the first 6 months of the fiscal year. I will, in a number of the areas where I'm going to present, cover longer periods of time to sort of provide both sort of background reporting data as well as trends over time for a number of the indicators, because sometimes it's important to look at current performance in the context of prior performance in past years. Before I actually get into the presentation, we have a short couple of minute video we want to play, which is just a semblance of input from our staff across the organization. As Mel said, nothing would happen in this organization without both the donors and our employees. And this past October was the first anniversary of our brand renewal. And so we captured a little bit of input from staff at the time. So if we can just quickly roll the video and then I'll get into the report.
We are Canada's biological lifeline.
We are the connection between the sincere generosity of donors and the heartfelt appreciation of recipients.
Between the profound discoveries of science
and the joyful restoration of health.
As such, we are nationally responsible for a secure system of life essentials for transfusion or transplantation
that's reliable, accessible, and sustainable.
That's why our organization must be efficient, our performance disciplined.
We must work as one with our colleagues and partners at all levels.
We must be prudent yet smart, rigorous yet agile,
capable yet concerned.
And we must be innovative, reinventing today so we can find better answers for tomorrow.
In a very real way.
What we do affects the well-being of all Canadians, and every day we must earn their trust.
We make a difference, and in that we take great pride. Together, we are Canada's lifeline.
So just a quick snapshot from folk right across the country.
If I could just add, you will have noted that on these images, which you see on our trucks and on our plaques and billboards, these are real people. You saw some of them in that video. And so these aren't actors, although they may be very good actors. They're actually real people, and they're either staff or recipients or contributors or donors. And so it's important to note that.
Yeah, absolutely, Mel. All of the imagery used in the brand renewal derives from, as you say, those three categories: donors, recipients, or employees and volunteers. All right, so what I'm going to do, for some reason the clicker is not working, which is going to make life very difficult. So I'm going to move through a series of slides, and I'm going to just cover a bit of operational performance. Then I will talk about the strategy of the organization and also cover some of the financials. If I just sort of look at the first half of 1920 in a very high snapshot, you can see here a bit of a summary. So I would say that the first 6 months shows strong operational performance in whole blood collections. We did a very good job of meeting hospital order rates. I'll talk about a major achievement in the stem cell program where we achieved accreditation by a very important global body known as the Foundation for the Accreditation of Cellular Therapies. I'll talk about the execution of our new strategic plan, Keeping the Promise. Mel already touched on the launch of our plasma proof of concept program, and I'll give you a bit of an update on that. In the organ donation space, I'll give you a number of key highlights, but I would say one of the most important achievements for the first 6 months was the beginning of the work we're doing with the transplant programs across the country and the provinces to now ensure the ability to share hearts across jurisdictions, much as we currently do with kidneys. And Mel has already touched on one of the important governance highlights, and that's the National Accountability Agreement. So in October, well, the end of September, early October last year, I actually hosted an event in Calgary at our new facility. And of course, as board members know, we're going to be hosting the open board meeting in June of next year at this new facility in Calgary. But I actually participated in an event there with the local employees to essentially do a brand anniversary. It was broadcast across the whole country. And here you can just see a picture of me with 4 of the individuals who work in Calgary, and we had a bit of a Q&A and a dialogue on what does the new brand refresh mean for employees and how they do their work. And it was a great session and generated a lot of really important buzz across the organization. In terms of brand, and I mentioned this to the board a year ago when we launched the new brand, one of the things we want to do is to make sure that the brand is actually helping deliver the value proposition. So this wasn't about a new logo and a new color scheme. It was really about, is the brand helping us articulate the mission and the vision? Is it helping us bring donors in the door? Is it helping us build trusted relationships with our key stakeholders, and so on? And working with one of the firms who knows Canadian Blood Services very well and does a lot of work in the space, Ipsos, they have what is known as a brand equity score. So this is a common measure used to assess the validity and the value of an organization's brand. And a brand equity score is made up of these 4 components: familiarity, trust, relevance, and uniqueness. Now, unfortunately, we were not measuring a brand equity score with our prior brand, so I can't give you sort of comparative data last year, but we did gain baseline data at September of 2018, so at the time of launching the new brand last September. And you can see here on the right-hand side of the slide the 2 important numbers. So the brand equity score, which is a composite of these 4 factors made up by a variety of questions that assess familiarity, trust, relevance, and uniqueness, both in the donor population and in the general public, have gone up marginally in the first 6 months compared to the baseline from September. And what Ipsos tells us is actually many organizations will experience a dip in your brand equity score post-renewal because there's actually a loss of familiarity when an organization launches a new brand. So they said when you actually maintained a score, even saw a slight uptick, that's a good thing. What I think is most important is what this will track over time, because a brand equity score is a long-term measure of an organization's relevance and relationship with its key stakeholders. So the board and certainly members of the public can expect to see this from us twice a year. We've just gathered the year-end data, so September 2019. We've just finished that analysis in the field now. The data is being crunched. We don't have the numbers, but I'll certainly be able to report that at the next board meeting in terms of what the brand equity score is 1 year post-launch. So I guess a little bit of good news at the outset, but watch out for some more as time goes along. All right, what I'm going to do, exactly as Mel said, we have the 4 major product lines, and I'm going to give you a quick snapshot of performance across each of the product lines. And of course, as I've said to the board many times before, just throw your hand up while I'm yakking on. This is really intended to generate questions, and feel free to stop me if you want explanation on any additional data. So if I look at the blood program for a moment, some of the major highlights, and I'll dig into these. From a safety point of view, we obviously have a very active program in terms of surveillance and monitoring. I will talk about a number of the specific agents that we are paying close attention to, but I think it's fair to say in the first 6 months of this fiscal, while there's a very active surveillance agenda underway, there are no new emerging threats that require additional action beyond what we're doing now, and I'll expand on a couple of those later on. I talked briefly at the outset about inventory and meeting hospital needs, strong ability to deliver blood to the hospitals. You'll see I'll share some data in a few minutes on some collection challenges we're facing, particularly in the area of group O negative red cells, and I'll show you some very important data in terms of the demand on this particular sentinel product that is so essential for patients with trauma and in a variety of other other unique transfusion circumstances. And one of the areas where Rick and his team have been doing a very lot of work, and I'll show you the numbers in a minute, is in helping minimize wastage in our environment. And wastage can occur throughout the supply chain from collection through the manufacturing process. And we track this indicator called red blood cell discards, and we're now actually measuring the lowest level of discards in the history of the organization. And I'll show you a chart on that in a sec.
Just a question, though. Would I be wrong in saying that there are two kinds of errors, having too much blood or not enough? And if I have to choose one of those errors, we're in the right position.
Absolutely. I mean, this is the whole sophistication of inventory management, Mel. You're absolutely right. It makes no sense to constantly overstock and waste it because, one, it's very expensive, and then you're certainly not valuing the donation that a donor is giving, because really people are giving with the intent that it's going to be used by a patient. So if we're simply hoarding, if you want, and then throwing it out, it's really very bad inventory practice. But if you're going to err on the side of something, you rather want more on the shelf than less, because less is way more problematic from a patient point of view. But and in fact, one of the things that Rick's team has done is begun to put in guard bands on inventory, tracking both the upper level and the lower level. And whereas we always used to focus on the lower level, I think it's fair to say, Rick, we've now got as much attention on the upper guard band. I don't know if there's anything you want to add to that.
No, that's correct, Graham. And the other important point here is that as a national system, we are every single day moving units around the country to ensure that we are moving product that may have an exposure to some level of expiry into areas that might be somewhat understocked. So we, for the board's awareness, move several hundred units of product every single day.
Okay, and I'll show you some data on inventory in a sec. All right, so on the safety point of view, I thought I would just highlight a couple of key agents. West Nile virus is an interesting one. So this has been with us for about 15 years now. We began testing for West Nile, I think in 2005 approximately. And every year there's a different number of cases breaking out in the country, not just in blood donors, but in the general population. And it's very hard to predict what the seasonal rate of West Nile will be. We have to be ready irrespective of a major outbreak in the country or a very low outbreak. And it's a typically summer agent. Because it's a mosquito-borne virus, you tend to see it in the late summer once the mosquito population has peaked. And this past summer, so you can see data for the most of 2019, but all the cases occur in sort of June, July, August, September. You can see we've had exactly one positive donor in the country, and in the whole of Canada, amongst the public health data, there were 28 cases of West Nile. If I compare that to last year, we had 48 donors, and there were many, many, many hundreds of cases across the country in the general population. So this is the tremendous variability we see. And certainly one positive in a season is exceedingly low. We've never had a zero. And the year before, 2018, the 48 year, was in fact the second highest year we've ever had. So you can see this dramatic variation, and our system has to have the capacity to pick up whether it's low or high. And
so are we now seeing West Nile in all of the provinces? That's my first question. And my second question is, if you see it in all the provinces, does it mean that next year it will be in all the provinces as well, or is that seasonal?
Yeah, so we're not actually seeing it in all the provinces. I don't believe in our history we've had a positive donor in Atlantic Canada. Maybe we might have had one, I think, in the entire history of CBS. There may be a few cases. Israel, I don't know if you know what the public health data is for the East and even the West. BC has very low incidence of West Nile. It is mostly Saskatchewan, Manitoba, and Ontario, by far away, the majority of the cases. This donor was in Ontario, where generally we see most every year. Saskatchewan often has the highest incidence, and that doesn't predict what the next year is going to be. This is what makes it so challenging.
David?
Thank you. Continue to address the post-travel donation deferral. Can you explain that? And And what's the timing involved?
Yeah, so this second bullet on this slide then, so I've talked about West Nile. Then, of course, one of the other areas of infections that we pay close attention to are a whole category of what are known as mosquito-borne viruses. So you hear in the media things like Zika virus and chikungunya virus and dengue virus. These are all viruses that come from a similar sort of class of agent, and they're all spread through mosquito vectors. And so we and other blood services around the world pay very, very close attention to these. So Zika virus is a classic one, for example. We don't test for Zika virus, but we certainly ask donors based on travel history if they've been to areas where some of these viruses may be prevalent. And so post-travel donation refers to, we ask donors a lot of questions on their travel history, and based on their travel history, they may be deferred for a period of time and not allowed to donate in several months post-travel because they may have been exposed in a malaria area or some other area where there's a mosquito-borne virus like dengue, for example. So we don't test for all of these, and in some cases there aren't tests, but you rely on this capture question of travel exposure, and that's what that. So we do a lot of our donor screening is intending to identify people who've been in high-risk areas, and then you may defer them based on your criteria for a period of time before they can donate again. And it's a big problem for us because people often go to the Caribbean and then they're deferred, and then they go back to the Caribbean and they're deferred again. And so it's an area where the medical group does a lot of work to monitor this. Two other agents, very briefly, and we talked to the Science Research and Ethics Committee on this a lot, Babesia and hepatitis E virus. The board knows we are monitoring both of these very carefully. Babesia is not a virus, it's a parasite, but this is one that we've done extensive risk analysis on. We've worked with colleagues in the United States. We've used our risk-based decision-making framework, and as the board knows, we have a very, very active surveillance and monitoring program in place here. We actually identified an individual who turned out to be a positive donor, and then we do what is called a look back. So somebody who is identified as having Babesia, you look back at all their prior donations and you see if the recipients of those products acquired the disease, and in this case there was no transmission to the recipients, and that's quite common with Babesia. It is not easily transmissible through blood, although it is known to be transmissible. So that's Babesia. Hepatitis E, we've talked to the board a few times about this. This is a virus that occurs mostly from eating poorly cooked pork products. It's much more prevalent in parts of Europe than it is in North America. And as the board knows, we've done extensive seroprevalence studies, and we continue to do modeling studies to look at the risk of hepatitis E virus in the Canadian blood supply. And we're working closely with HEMA Quebec and Health Canada on this. And at the moment, we have a sort of an enhanced awareness and surveillance program to minimize the likelihood of hepatitis E becoming of concern in the Canadian blood supply. I'm going to just mention this one briefly, Mr. Chair, chronic wasting disease, because in fact, 2 or 3 of the presenters later this morning, are going to address concerns around this. But I think it's fair to say a couple of things at this point, and Israel will expand on this later on in the morning. So chronic wasting disease is one of these diseases in the category of prions, so these abnormally folded proteins. You hear of things like Creutzfeldt-Jakob disease and variant Creutzfeldt-Jakob disease. They're all in the category of prion diseases. And chronic wasting disease is a disease that does not occur in human populations, but it does occur in elk and moose and deer and those sorts of cervid animals. First identified in the Midwest of the United States many decades ago, but has been prevalent in herds of deer and related populations in northern regions of this country, Saskatchewan, Alberta, and more recently in parts of northern Quebec. So certainly there is evidence of chronic wasting disease amongst certain herds in this country. And so many people have wondered whether this is a risk to humans and therefore a risk to the blood supply. There is no evidence that this is a threat to the blood supply. There is no evidence of chronic wasting disease in humans. Nonetheless, we and other blood services in the United States and elsewhere are paying very close attention to this one, monitoring the epidemiology epidemiology very closely, working with Health Canada, the Canadian Food Inspection Agency, and others to make sure that this is not an agent that jumps into the human population and potentially becomes a concern to blood safety. So more on that for sure. Moving from safety into supply, just a number of quick slides here. This one shows our ability to deliver blood to hospitals. So we measure the order fill rate, which you can see for the first 6 months of this year was 99% against a target of 98%. So we're ahead of target there. The red lines are going down. And what are those red lines measuring, those red bars? They're measuring the total number of red cells that we ship to hospitals every year. And you can see it has been a downward trend for the past 6 years. We are shipping less and less red blood cells to our customer hospitals every year. And this reflects the slow but continual decline in the demand for red blood cells as there are improvements in surgical practice, improvements in medical care, new types of cancer chemotherapy drugs that are less damaging to bone marrow, so therefore make patients less anemic and so on. So the demand for red cells is going down slowly. And you might ask, is that unique to Canada? And I wanted to just show this slide here. I've spoken to the board about this before, but this is 4 countries. So we're the red line. NHSBT is England, the National Health Service Blood and Transplant, actually in all of the United Kingdom. The black line at the bottom is the Australian Blood Service, and the light blue line at the top is the American Red Cross, which is the largest collector in the United States. And you can see in all 4 of those countries, there is a gradual decline in the amount of red cells that are used in those markets. So Canada, Australia, and the UK, almost identical trends. And we're transfusing at a number which is measured as the number of red cells used per 1,000 population. And you can see we're all around 26. The United States simply uses more blood per capita. There's some people would argue that's driven by the higher gun incidents and blood and shooting incidents, but they simply use more, but nonetheless still seeing a downward trend. Kelly.
Graham, have we bottomed out, or do you still see it declining in the future? And if so, why?
Yeah, and every time I go to the ABO meeting, the Alliance of Blood Operators, we try and buy the better crystal ball than the one we bought last time. And we haven't yet found the ideal one, because all of us are struggling to answer that question. And it's a really material question from an operations point of view, because you build your infrastructure and you model your collections requirements based on what you think the future is going to be. So we don't know, Kelly. And I think the only perhaps important inference we draw, if you look at this slide here, is that the rate of decline appears to be slowing. If you look at sort of a few years ago, 3%, almost 4%, then 2%, then down to 0.6 and 0.9. But then you look at 17, 18, it was another 3% decline. So we honestly don't know. When we talk with our clinician colleagues, those who are actually prescribing red blood cells, most would say there is still a ways to go to further reduce the use of red cells. So I don't think we've bottomed out, but I really do believe we're seeing the decline slow. The question is, at what point, if any, will it rebound, and will we see the demand increase? And then we have to have the capacity to build a donor base to support that. Jeff?
So CBS does a lot on education of physicians around the utilization of blood and blood products. What is your sense of the appropriateness of the use of the red cells at the moment? Are we good in Canada? And I mean, are we ways to go?
Actually, and we'll talk about appropriate utilization in other areas later on in the deck, but I would say when it comes to red blood cell use, we are probably one of the leading countries in the world, and we were there earlier than most for very unfortunate circumstance. The years of the tainted blood scandal, and I was, of course, a prescribing physician in those days, for all the wrong reasons, Canadian physicians became extremely good at minimizing exposure of their patients to red blood cells. This was driven out of safety concerns for HIV and hepatitis in the 80s and the 90s. So we put in place a lot of restrictive transfusion practices long before many other countries did. So I say for the wrong reasons, but for the right outcomes in terms of patients. So I would say, Jeff, red blood cell use is very, very largely appropriate. There is an initiative, triple aim, it's I'm blanking out on the name of the initiative, it'll come to me in one sec. It was
Patient blood management.
Yeah, and it's the initiative run by
Choosing Wisely.
Thank you very much. So there's an initiative, it's actually a US-Canadian initiative called Choosing Wisely, and it's not unique to blood and transfusion. It's about identifying the best indicators for any medical intervention, whether it's a CAT scan, a pap smear, a red blood cell transfusion. And we have done a lot of work with the clinicians in this country using the Choosing Wisely framework to optimize red blood cell use. So I think we're pretty good. Not the same for other products, perhaps, and I'll show you some of those later on. Okay, I'm going to move on. This is the other one. I mentioned this in my opening slide. This is an important data point and something just for the board to appreciate that management spends a lot of time on. So the purpose of showing you this slide here is simply to show you that black line, really, which is the trend line of the red bars. And that trend line is the proportion of red cells that are O negative. So of all the red cells that we ship to hospitals, what percentage are group O negative? And you can see that we're shipping about just over 12% of all red cells today are group O negative. And you might say, well, what's so important about that? What's so fundamentally important about that is only 7% of the Canadian population is group O negative. So our donors who walk in the door, only 7% of those have this blood group. From a use point of view, our customers are taking 12% of the red cells at this rate. And that is driven by this being the sort of unique product that serves trauma patients and emergency use circumstances. So if you want, it's your premium product. So Rick's team has a lot of initiatives in play to sample the donor population for group O negative to build a greater percentage of your donor base who are O negative individuals, so you can constantly meet this need. And it's another trend line question, Kelly, what is the end game here? And in Australia, they're actually shipping 14% of their red cells are group O negative, and they have many periods of severe shortage of group O negative. So this is, it's a very tactical issue in some ways, but carries a lot of importance from a patient care point of view. And this was the one I mentioned about wastage or discards. You can see here the downward trend over many years, bringing us to 5.3% in this fiscal year, forecasted year to date and forecasted to year end. And we calculated from if you want, a cost of quality point of view, by reducing the discard over time, what are the costs that we've avoided by allowing the product that we've collected to be used rather than thrown out. And you can see that over this time, it's about a $13 million cost avoidance simply by reducing the discard rate. And I just want to stress, the very large majority of discards are not outdates. Outdates is a tiny percentage, actually, as low as 0.1% of the discards are outdated. These are things that happen throughout the production and collection process. So a donor may be donating a pint of blood, and the bag doesn't fill properly, and then the needle has to come out. So it's called an underweight collection, and it gets thrown out because it can't be used. Or it may, in the production laboratory, it may leak in the centrifuge, and so you can't. There's a whole variety of reasons, and Rick's team has many, many initiatives to reduce all of those across the supply chain. A very important set of activities from a quality and a safety and an efficiency point of view.
Graham, if I could move back one chart on the O negative. If we ran out of O negative at a period of time, what action would we take to ensure that our patients get what they require?
So I'll offer a brief comment here, Dunbar and Isra, if you want to add, feel free. And this sort of a little bit also touches on Jeff's earlier question around appropriateness of use. This is one area where we actually do a lot of work with the clinicians to monitor appropriateness, because there are some situations where group O negative red cells are being prescribed where a group O positive or in fact a matched unit, A positive or whatever, would be better. And so there are circumstances where it's being used where frankly a patient doesn't need it. There are some circumstances where it's absolutely essential that a patient gets a group O negative. So we've never come to a situation where we've run out, but we have certainly faced situations where our inventory of O negative is exceedingly low. And so then we will go to some sort of heightened donor, I don't want to call it an appeal, but an outreach to donors, knowing their blood group. We'll connect with O-neg donors and say, we need you to come in because our inventory is exceedingly low. So we have that ability to do that, but you really want to be able to manage it on a more normal basis than have to appeal at times when your inventory is very stressed. And I'll make just one last point is, when our inventory is very low, we also work with the hospitals to understand their inventory. And not infrequently, we're worried that our O-neg inventory is down at 2 days, and they're sitting on 10 days of supply. So we've also got to have a system-wide view, and that's why you'll later on hear me talk about initiatives using digital technologies to understand line of sight into hospital inventory, because that gives you a system-wide view as opposed to just what's on our shelf. So there's a lot of things, a lot of levers we can pull to manage this, but we're pulling a lot of levers to manage this, and that's the problem.
I'm just curious, do you continue to discuss as groups of blood organizations the use of artificial red blood cells, or are we still trying to develop that as an alternative if things get too difficult?
Yeah, it's only been 65 years in the making since the Korean War, as you probably know, Brian. That's when the first research into so-called synthetic red blood cells began, sponsored by the US military. And I'm afraid to say it's not that much closer to reality. It's really interesting. You know, from a biological point of view, we've been able to engineer all sorts of artificial substitutes for proteins and organs and tissues and all sorts of things. But there is not a single study that sort of innovation in the commercial sector that has come close to making synthetic red cells a viable opportunity. There were a few clinical trials a few years ago, and they all ran into major toxicity problems. So this is not going to be solving our problem. We've reported to the board previously, one of the areas of research that CBS actually sponsors and one of our scientists in Vancouver works on is not artificial red cells, but is actually trying to mask the blood groups on the envelope of a red cell, so to make every red cell the same, whether it's A, B, O, positive or negative. And that would help in inventory management, but it wouldn't replace the need for human donors. So that's one area of research that we think may be more promising, but I don't think in my career we will see a truly synthetic red blood cell. Okay, moving on from red cells to platelets. Those are, of course, a very important fresh blood component, mostly used to treat cancer patients and heart surgery patients to prevent or minimize bleeding. And this slide, there's 2 points I want to show you on this slide. So one is, unlike the red cell story, the platelet story is a little bit in the opposite direction. The demand for platelets is slowly increasing, not decreasing, at around 2% per year. And you will see in the 17-18 and 18-19 window, we changed our manufacturing process and our storage process. So instead of storing platelets for 5 days and then expiring them, we were able to store them for 7 days because of a series of interventions that we put in to minimize the risk of bacterial contamination. So in that time period, we saw a transient dip in the amount of platelets we had to ship to hospitals. Because we had a longer shelf life, there was less wastage. Platelets have a very, very high outdate rate because of such a short shelf life, originally 5 days, now 7 days. And so in that period where we introduced 7-day expiry labeling, we saw actually an improvement in our inventory, and therefore we needed to collect and ship less because hospitals were wasting less. Now that that's become the new normal, you can see that the demand is back up at about 2% growth per year, and we predict that this will continue for the time being. This is driven by more and more cancer therapies, more and more heart surgeries and what have you, and it's really driven by clinical demand. Yeah.
Grant, we've heard a lot about how we have a lot of efforts going on to increase the blood donor supply. How do we recruit for platelet donors?
So
how's that going?
Yeah, so that can be partly answered on this slide, Craig, in two ways. If you look at the blue bar graphs, those are platelets that are made off the pint of blood, the whole blood donor. So you're recruiting a blood donor, and in the laboratory, in the manufacturing facility, we're separating it into red blood cells and platelets. Those are so-called pooled platelets derived from a unit of whole blood. So you're not actually recruiting for platelets there. You are recruiting a blood donor. And you can see in Canada, about 80% of all our platelets come that way. The red bar are your specific platelet donors. So you want somebody to come in, sit on a machine for an hour and a half, and you're only collecting platelets from that donor. You can also siphon off some plasma, and that's the donor that Amy was referring to, who she saw in Ottawa. It was somebody donating a unit of platelets from which we can also collect some additional plasma. So those are your specific platelet donors, and we have a very dedicated cadre of platelet donors in the country. They're your super elite flyers because they donate more often. It's a much longer time commitment. And you have, I think, dedicated recruitment activities at these donors. I don't know, Rick, if there's anything you want to add to that.
Yeah, no, that's correct, Graham, and it's a targeted effort to fill those beds principally through our national call center. We do have higher apheresis collections in relation to pool than it may be necessary, so you might see a shift in the proportion of red versus blue in outer years. And the apheresis platelets, the red bar, are way more expensive. It's a lot more expensive to make a platelet that way than to derive it off a whole blood collection. So the more we can shift to whole blood platelets, which have in some ways actually better quality, there's data to show that the quality is actually better that way than apheresis. It's both cost effective and a good quality intervention. Okay, so that's blood and platelets. Jumping to plasma now, our next major product. So we've touched on some of this. I'll just mention a couple of additional highlights, and you're going to hear about this one later on. So one of the products that we were able to introduce onto our formulary recently is this new type of therapy for hemophilia A patients who have inhibitors, 2-factor 8. This is a drug called emicizumab, or its trade name Hemlibra, and the board has heard both from the Hemophilia Society before and from management about the importance of this drug for that particular cohort of patients, and it is now on our formulary, and we're very pleased to have introduced that in the last 6 months. You're going to hear a lot through the public presentations this morning around the management of the immune globulin scenario. You heard Amy's story, but the board is very well aware of the challenges we faced in the first 6 months of this year around sufficient access to subcutaneous immune globulin. It was not unique to Canada. There is a global challenge in inventory management with immune globulin, both subcutaneous and intravenous. We had to work exceedingly hard to manage a situation in this country. I will show you some data on this, and you will hear from members of the public about how this was managed, but I wanted to just at least address it in the highlight. Lorraine.
Being a new board member, 9 months anyway, Cadith, what is the average time frame for them to make a decision?
Isra, do you want to?
I believe the Cadith recommendation generally is within 6 months. It's a very well-specified, transparent process.
And I will you can see at the bottom there, we have ongoing collaboration with them and the provinces to modernize our selection process, and I'll give you a bit of an update, and Isra will also speak to that later on in the public presentations.
Just picking up on Lorraine's point, that, Isra, if I understand, is what the proposal that goes into that approval process is for. And so if it was for emicizumab with inhibitors, there would be a different proposal for without inhibitors. Is that right?
Yes, it is. And actually, I should also qualify, that is the review period from the time of submission. I mean, often one gets into comparisons of different processes, but people vary in the interpretation of when the process starts and when it stops. So the CADIT review, which is limited to receipt of submission, receipt of submissions from interested groups, contemplation by scientists, recommendation by peer review and expert panels, and then the issuance of a recommendation. That recommendation would be picked up by governments and funding agencies and consideration given. So it isn't the starting point from the arrival of a new product in the market to availability for patients. It's just the review process. Yeah. And as you say, Mel, the review for any particular drug in particular circumstances would be redone if there were different circumstances.
And we'll talk about some of that in more detail later on.
I might be wrong, Mr. Chairman, but I remember the last couple of open meetings we've had, there have been a number of people talking about this process, and I seem to remember that the message generally was it was sort of wiggly and not very effective or efficient, and took a long time for a drug to go from here to there. And I'm just wondering, have there been changes made over the last period of time and in response to some of what we've been hearing, and so that we're now into sort of a much more effective and efficient sort of process to review these new drugs?
So I'm going to preempt that discussion now because Isra's going to provide a bit of an update. You're also going to hear from David Page from the Hemophilia Society, who certainly wants to express the concerns on behalf of the, patients with rare blood disorders around the whole process. But the short answer to your question is yes. We continue to work with both CADIT and the provinces. We have developed an interim modifications to the process, which are now in place and posted on both our and CADIT's website. But there are still other components that is not yet resolution to, such as what are the criteria that defines how a drug gets into the process. So wiggly, yes. Fully resolved, no. But improvements underway, absolutely. So, and I'll let Isra expand on that later on. And here's the very slide that addresses that, Dunbar. So the interim process is now in place on the websites. It does provide greater transparency, more collaboration, and better information sharing, not to the full satisfaction of all parties. And you're going to hear from David Page later on, who will very eloquently express some patient perspectives on that. But our commitment is to ongoing improvement of this process, and in particular, resolving with the funders what are the criteria that are, that we all agree to, that defines how a drug gets into the process before any decision is even rendered. So, and you'll hear that from several patient groups later.
And then it's still up to each province. CADIT is not the final.
So it is up. So depending on what the outcome recommendation is, if it's to go into Canadian Blood Services formulary, then it's of the collective. If it's to be managed through the Common Drug Review and on individual drug plans, as is the case in one of the drugs, then indeed it's up to each province to make their own decisions. So, when CADIT made a set of recommendations and the provinces agreed that they would fund the acquisition of Hemlibra through Canadian Blood Services for hemophilia A patients with inhibitors to factor VIII, they all had to agree so that we could put it on our formulary. That is different than if a drug is going to be managed on individual drug plans. And so it is a very complicated set of decisions at all times. So we'll revisit that a few times over the morning. Let me just move then on to some trends in use through the various major categories of plasma protein therapies. This is the first one, immune globulin, the one we spend a great deal of time talking about for all the right reasons. I wanted to show you some trends in use over the past 6 years or so, and you can see in Canada we're seeing about a 9% annual compounded growth rate. 51% over the past 6 years. And the important other data point on this slide is the size of the blue bar is growing, and you can expect this to grow substantially relative to the overall height of the bar, and that is what percentage of all immune globulin products are going to be subcutaneous. You heard Amy's story. It is certainly preferable from a quality of life point of view to deliver your therapy to yourself at home. And this is also driven in some part by trends and going on inside the acute care sector, where there are not enough beds in hospitals for hospitals to be bringing patients in for intravenous therapy. And if there is a so-called subcutaneous therapy that can be delivered at home, it has a system-wide benefit, not just an individual patient benefit. So there's a lot of drivers that are causing patients to move to subcutaneous therapy, but that has implications from a manufacturing point of view. You need more plasma to make the same amount of immune globulin for subcutaneous use. It's a more expensive manufacturing process, and so on. So very important system-wide implications. This is the major drug for hemophilia, factor VIII. There are other hemophilia drugs, but this is the sort of headline one. And you can see about a 4% annual compounded growth rate, and that's pretty static year over year. And it's not that there are more patients being born. I mean, patients are born with hemophilia every year, but this drug is given based on body mass. So as the boys get older, they get bigger, and so they'll end up using more factor VIII entirely appropriately. And over the past number of years, there's also been a trend to move patients from only getting the drug when they have a bleed to prophylactic therapy, so you prevent bleeds. And that shift in the type of therapy also has helped drive up the use year over year. And the other data point here is what's the blue bar? The blue bar represents these newer factor VIII molecules that have a longer half-life. That means you can give injections less often to the patient, so it's better from a quality of life point of view. And you can see that's about a quarter of all the hemophilia now in Canada is the so-called extended half-life. Not shown on this slide is that new drug Hemlibra, which is the very new molecule that is even different from these types. But this has been the impact of the introduction of Hemlibra in the first few months of this year. These were predicted because Hemlibra is such a powerful drug in patients who have inhibitors to factor VIII. You expect fewer bleeds in these patients, and you expect them to need less therapy to manage their bleeding situations. And so here's a couple of drugs here. FIBA stands for factor VIII inhibitor bypassing activity. It's a drug that is used in patients who have inhibitors with or without bleeding episodes. And this drug called 7A is also used in patients who have inhibitors to factor VIII. And you can see these have had a significant reduction in use. And we believe to a very large extent that is the impact of the introduction of Hemlibra. Certainly true for FIBA. The 40% reduction is driven by Hemlibra. The 7A is used in other circumstances, and it's a drug that goes up and down every year, so cause and effect is a little harder to show there. Nonetheless, we forecasted, and you're seeing here, many millions of dollars of savings to the system by the introduction of Hemlibra for patients with inhibitors. Expensive drug, but actually a system-wide saving, and that's what CADTH identified in recommending approval of this drug for this cohort of patients. And the third one I'll just quickly touch on is this drug or class of drugs called C1 esterase inhibitors. You're going to again hear from the representative patient population, the hereditary angioedema patient population. This drug has been the fastest growing drug on our formulary for some years now, almost 30% annual growth rate. You can see a 250% growth over 6 or 7 years. And this is the one we mentioned to one of the committees the other day. Israel and his team, along with others, are sponsoring a forum in Toronto next week with the hereditary angioedema community, the prescribing physicians, the patient groups, provinces, and others, to try to understand what is the long-term trajectory on the use of this very expensive therapy for this patient population.
So, Graham, on the C1 esterase growth, is that something that other countries are seeing as well, or is there anything unique in the Canadian?
No, this is for those countries that have introduced, and there's different brands and different categories of C1 esterase. Some of them are plasma-derived. There's newer ones that are recombinant. This is being seen in many other jurisdictions as well. I don't have the numbers in terms of the rate of growth, but I would say it's not uncommon to see growth rates around the world of this. It's a relatively new drug. I think it was introduced in 2010-11, if my memory serves me correctly. Relatively new, and this is a fairly large cohort of patients, some of whom are not yet fully diagnosed. And so you're seeing more patients go, once identified, are then being appropriately prescribed the therapy. And so I think this is true in many markets around the world. Certainly in high index developed countries, you're seeing a demand for this drug go up. It's not unique to Canada. I don't know what its reimbursement status is, for example, in many European countries. I'm just not familiar with that. All right, moving to our third product line, stem cells. I mentioned accreditation by FACT, a major achievement this past 6 months. I'll mention GRID in a moment. It's an important initiative, and we thought we'd just call out that the head of our stem cell program, Dr. Elma Wazen, who is not hanging over the railings, I don't think, has just recently been inducted as the chair of the Marrow Donor Association Cord Blood Working Group, so a very important feather in her cap. Just some data to show you trends in stem cell use. So this is cord blood. So as the board knows, we've been banking cord for about 6 years now. And you can see the growth rate in the number of cords that are now in our bank suitable for clinical use. It's about 3,400 at the moment and continuing to go up. We've collected about 28,000 cords, but not all collections make it into the bank because they may not have the right cell count and they may not pass quality control. This is a slide I wanted to put in. I've not shown it to the board in the past, but it's an important slide because one way of measuring the success of a cord blood program is to say, of all the samples that you bank, do they get used? Is your bank actually attractive to transplant centers around the world? Remember, in the stem cell business, we support not only Canadian patients, but we're part of an international network where our bank and our adult registry are linked to all the other banks and registries around the world. So this is relatively new data for us, and it shows you what is called the ship rate. And it's very low. Let me be very clear. You're not shipping 50% of your banked cords. The demand is exceedingly low because you've got to find the perfect match, and you need a very large volume to find a match. And Canada is currently shipping, Canadian Blood Services is currently shipping 0.32%. And you might say, well, that sounds ridiculously low. Well, it's actually totally in line with the best in class in the world. The average, the average amongst all the good services is about 0.33. The leader in the world is the UK cord blood bank, the Anthony Nolan Bank, which is at 0.42. Hema-Quebec is below 0.1 almost. And the very large, one of the largest banks in the world, the German one, ZKRD, is actually shipping at about 0.05. So this is an important indicator of success and one that we are proud of, but obviously one that we need to pay attention to. David? What's the number in terms of how many? We have shipped 24 as of last week and a couple more in the works. 24 out of the 3,400 that we've banked.
So my question is also about numbers. You mentioned we currently bank 3,500. What's the goal for how many would we like to have in our bank, and what's actually the capacity that we have in our infrastructure? How many could we hold? Two very important questions, and I will be brief in my answer. When we built the business case many years ago, the target was 20,000. We wanted to bank 20,000 because we did some modeling at the time with the Germans and others in the US who had much bigger banks. And we said, based on what we understood, the demand for cord blood at the time and the HLA, the tissue diversity of Canadians amongst the various ethnic populations, we needed a bank of that size to meet patient need. And no sooner had all that modeling been finished, and then the demand for cord blood just fell right off the roof. And as you know, I've shown that to the board in the past. Cord blood transplants are much less common today than they were a few years ago, displaced by things such as half-matched transplants called haploidenticals. So everybody around the world has gone back and remodeled what is the right size of inventory. And so we don't need 20,000 in our bank. We actually have freezer capacity for 20,000, but we probably need closer to 8,000 to 12,000 would be an optimal size bank
based on current demand trends and current tissue diversity amongst the Canadian population. There are some banks, some shown on this slide here, the German one, the NMDP in the United States, the New York Cord Blood Bank, that have tens of thousands of samples banked, and they're throwing them out because they were collected many years ago. The cell count is exceedingly low. They're never, ever going to be used for transplant purposes. They don't meet today's quality criteria, and they're expensive to store because you have to keep the liquid nitrogen tanks active at all times. So a lot of banks around the world, older than ours, are culling their samples back to only keep the good ones. And so people are going back to remodel. Ours is still on the growth phase. 3,400 is small, and we will constantly remodel this as time goes along.
Another quick question. In our core bank, are we seeing the diversity representative of the Canadian population that we want?
So as you will recall, one of the indicators we set for ourselves in cord blood collection was diversity, because you want to make sure you're collecting from the diversity of the Canadian population, because those are, you match stem cell transplants based on tissue type, which is inherited along racial lines. And so we set up our collection centers in the most diverse parts of the country, Vancouver, Toronto, Edmonton, and Ottawa. And we have targets of diversity measured on either Caucasian or non-Caucasian, and within the non-Caucasian is a long list of multiple ethnicities, and we are hitting the target of 40%. No, 40% of the cords banked are Caucasian, 60% are non-Caucasian. So we're pretty much where we want to be, David. But we're constantly also modeling that number as well.
Graham, we've started to provide feedback when there's a receipt of our blood or a blood product to donors. And do we provide feedback, small numbers, to the family of when we've actually used cord blood from our registry, from our storage?
We don't, and we're not allowed to, actually.
Oh, right.
And there's a blackout period between when a link between a donor of either a stem cell, an adult stem cell, or a cord blood unit and the recipient. But I don't think we notify a donor mum that her cord blood has been used. I need to check into that, Jeff. We don't, do we? But I'm not sure we're actually permitted to. I need to look into the Heidi's not around issue. Good question. We'll get back to you on that one. I'm not 100% sure. I know that we are not allowed to link a donor to a recipient.
This is not on that topic, but could you go back to the previous slide? So I presume that all of these cord blood units are of similar quality. So the utilization isn't an indication that people are choosing higher quality countries to get their products from. They're simply choosing on the basis of the match. Am I being clear in my question?
You are, and I think they're actually choosing on both ends. So let me sort of try and distill this down. So Canadian Blood Services cord blood, we came very late to the party. We were one of the last countries in the world to build a national public cord blood bank. And one advantage of that is that we had learned all the lessons of everybody else. And we set for ourselves at the time the very highest quality indicators, cell count and a variety of other quality indicators. And we only banked at that level and above. Other countries many years ago were banking at lower quality indicator levels because they were, I thought, to be okay at the time, but today they don't pass quality standards. So they are now sitting on this inventory of mixed quality indicators. So when somebody searches our bank, the likelihood of finding a match is just that much higher in our bank than in others. But at the end of the day, a transplant center is going to choose a unit based on the degree of match and the ease of access. So if it's a Canadian transplant center, if it's the Hospital for Sick Children in downtown Toronto, and we can find a cord donor, it's the easiest and cheapest for them to do because there's no cost to them. If we have to acquire the cord unit in Germany for them, there's a very, very high transaction fee. So there's a whole number of factors that go in. It's geography, it's cost, it's quality. But at the end of the day, what the transplant center wants is the best match based on tissue type. Sorry, I'll just be brief on this slide, just to move us along. This is the adult stem cell registry, so this is not the cord blood bank, and it's a busy slide, but to the earlier question that David had asked on diversity, in the adult registry, we are also trying to recruit as donors two major demographics. Young males, males under the age of 35, and preferably young males under the age of 35 who are from mixed ethnic diversity, because again, those are the hardest to match patients, so we need more donors from that demographic. And so we have ourselves two targets, male donations and non-Caucasian donations, and we're hitting our target well, no, actually, we're not hitting our target for male. The target is 50%, and we're currently at 40%. And on the non-Caucasian, we have a target of 40%, and we're hitting it at the moment. So in the current quarters, we're hitting our non-Caucasian recruitment targets to adult donors to the registry. But if you look at the registry overall, the 450,000 donors there, only 33% of them are non-Caucasian. So we have a long ways to go there still. And this just shows you where do the products go from Canadian donors, whether they're cord blood stem cells or adult registry donors. How do Canadian patients get transplants? And so this shows you that two things. One is the bar graphs there's a trend upwards. You can see more and more transplants are happening in this country every year. But still, the very large majority of patients who get a transplant in Canada get it from an international donor. Our registry and our bank are still not producing the majority of the cells. And I just want to remind the board that we have 450,000 donors, registrants on our stem cell registry, but we're linked to 37 million donors around the world. So our registry is linked to other registries that cumulatively have 37 million donors. And we have 3,000 cords in our bank, but we have access to 780,000 cords from all the cord banks we collaborate with around the world. So we are a small player, but nonetheless a vital player. And we also provide samples to patients around the world. All right, if there are no more questions on stem cells, I'll move to organs and tissues. A couple of quick highlights. I mentioned this at the opening. We're now working with the transplant centers, the organ procurement organizations, and the provinces with the strong support of Health Canada here to evolve the Canadian Transplant Registry to the next most important use, which will be to use the system to allow the availability and access of heart transplants across provincial boundaries, which hitherto has been very, very difficult to do. It's really been used for kidney purposes. So that's the next major body of work underway. We did a work internally. Remember, Canadian Blood Services manages the Canadian Transplant Registry. So Ralph's team did a body of work to modernize the platform on which the registry is built and to ensure that it has state-of-the-art IT applications to minimize downtime and modernize the infrastructure. So that work is done, and we continue to collaborate with Health Canada and others in this Canadian collaborative for donation and transplantation. The board is aware, and I'll show you a slide in a moment on her last project, so I'll come to that in a sec. This is just one data point I keep bringing back to the board. It's just important to remind us all that the trajectory continues to grow in terms of the number of kidney transplants that occur in Canada through the registries that we manage, the highly sensitized kidney program and the kidney paired donation program. Before these programs were built on the registry that we now operate, these are the patients who never got kidney transplants. They were very, very difficult to match, almost impossible to match. Many of them spent their lives on expensive dialysis therapy and died waiting for a transplant. And so when you look at 1,285 here, this is a dramatic contribution to the improvement of patients with end-stage organ failure, in this case, kidney failure. We continue to do a lot of work in the public education and awareness space, and you can see just a few examples here. And Glenda was present at a number of events on our behalf this year, the National Organ and Tissue Donation Awareness Week on Parliament Hill, Green Shirt Day, sort of built on the tragedy of the Humboldt, Saskatchewan bus incident, and so that has spawned a very, very prominent awareness around organ donation, the so-called Logan Boulet effect, and others. And so we continue to do a lot of work in that space. And one other area of our mandate and responsibility in organ donation is the creation of professional education materials, and I wanted to just share with the board one body of work that Isra's team has done in the past few months with the clinical community is establishing and cultivating a national curriculum on identifying and referring suitable organ donors in the clinical setting. So the team collaborated with clinicians across the country to develop the Canadian Clinical Guide to Organ Donation, and it is now part of a national curriculum, particularly focused at, for example, critical care residents, so physician trainees who are becoming emergency docs or intensive care docs, where most of the opportunities to identify a patient who could, an individual who could become an organ donor occur. And so we are focusing this particular curriculum at that part of the professional body. And there's a lot of other work in that space as well. And the board is aware, we've mentioned this to you before, but just mostly for the members of the public to make us all aware, Canadian Blood Services partnered with the Health Authority in Nova Scotia to produce a vitally important documentary called Her Last Project, which aired at the Nova Scotia Film Festival a few months ago in September, had its world premiere there. I think Jeff and Judy were both there. And this movie called Her Last Project commemorates the story of a very, very brave Canadian individual, Dr. Shelley Sarwal, who was a public health physician in Canada, who was suffering from a terminal illness, multiple system atrophy, and chose to create a pathway to become an organ donor when she chose to have medical assistance in her death. So she availed herself of the legislation in Canada for medical assistance in dying, but in so doing also wanted her organs to be deemed suitable for transplant purposes. And prior to that, there was no policy to support that. There were no guidelines. And so Canadian Blood Services collaborated with the clinical community, with ethicists, with lawyers, and many others in the country to create the pathway. But she was really the sentinel individual who did that, and this documentary telling that story was created, and it's a very powerful film that is available to be watched. It's a 45-minute documentary.
Graham, just so you're aware, there was a screening of that in Winnipeg a few weeks ago, and I attended as a member of the board to watch that. It's a very compelling story dealing with two major issues within our healthcare systems, and I would urge anyone who gets an opportunity to see it to take that opportunity.
Thank you for that, Bob, and thank you for being present at that screening. We are, in fact, because we will be at your off-site early next year, we're going to show it to the board there as well. But if anyone has, and if members of the public want access to it, please connect with us. We'll help you get access to it. It's a wonderful, wonderful documentary. All right, I'm going to shift from the operational report, and I'll pick up the pace, Mr. Chair, to the strategic plan, and just a few slides to talk about progress against each of the 5 key focus areas. So as the board knows, we have 5 key focus areas in our strategy 2019-2024, and I thought I'd give you a quick update on what are we doing in each of the key focus areas. So the first one is meeting changing patient needs by providing life-saving products and services. So a few updates to the board here. One is we have collaborated across the organization, Isra's group, Rick's group, Christiane's group, the Center for Innovation, and others, to make sure we have an appropriate set of processes in place and an appropriate pipeline of products in our development sort of life cycle to make sure that we are developing products that are on sort of the horizon for patient need. And actually, you heard some of this from Dana yesterday, so I'll be very brief. But for members of the public, the three main areas of focus at the moment are LUCA-reduced cold-stored whole blood, which is being driven by trauma requirements, freeze-dried plasma, which is of high value to both military and pre-hospital trauma. What is pre-hospital? That means somebody picked up in an ambulance or on an air ambulance before they get to hospital. If you can give them this product, it's of very high life-saving value, and the board is well aware of the work we're doing on pathogen inactivation for platelets. So those are three major areas of focus within this key focus area. On that score, I thought I would just call out, since we're sort of in that time of the year, November the 11th, of course, we have a very, very strong collaboration with the Canadian Armed Forces in a variety of ways. Firstly, they are our largest partner for life. They partner with Canadian Blood Services to bring blood donors into our facilities, and we collect on a number of the bases across the country, and you can see that they're big contributors to our system. We support the Canadian Armed Forces in a variety of other ways when they are deployed across the world, and one of the areas of the product development, so the freeze-dried plasma, for example, is a product that is of high import and interest to the military. So that's one of the reasons we're collaborating with them to make sure we can meet their needs for soldiers who get deployed across parts of the world where access to transfusion is very difficult. I thought I would just call out under this theme of innovating products and services some of the work that our scientists do. These are three of our key scientists within our Center for Innovation, and just a bit of a snapshot of some of the awards that these individuals are securing, not just for themselves, but really for the work that they do, supported and enabled by Canadian Blood Services funding. So just a bit of a taste there, and we're always, very proud to see these outputs of high quality research. And I thought I would just remind the board that you were in Sunnybrook last September, if my memory, I think so. And you heard from the trauma surgeons there and the cardiac surgeons there some of the products that they were most interested in and some of the challenges they have. And all of the work we're doing on the products I just mentioned are driven by the sorts of clinical need that you heard there. You can see in the top left-hand corner behind the back of Mel's head is Dr. Jeannie Callum, and you heard her talk about a very important study she was one of the principal authors on, and that is the so-called FIBRES study, which is to introduce a new product, a fibrinogen concentrate product. That study just got published weeks ago. She and her colleagues presented it on the global stage in Texas in October, and that study, a Canadian study, is going to change the way cryoprecipitate and fibrinogen concentrate is used, and we were obviously partners in that study. So just the sort of innovation that occurs in Canada that we should always be proud to remind ourselves of. The second key focus area around donors, just a couple of thoughts I would show the board. One of the things we're interested in doing with our donors is actually understanding what motivates them to be a donor, and how do we know that the experience we're creating for them is actually valued. And it's all very good to say we're going to work on creating a great donor experience, but if we don't know that what we're doing is working, it's really hard to measure that. So Rick's team, supported by IT and others, have built an application to actually measure donor sentiment and donor satisfaction, or if you want, at a high level, what is the experience that donors have with us? And here we are using modern digital technologies, particularly this thing called natural language processing. So in the first few months of deploying this, so donors within 2 to 3 days of making a donation are given a link to a survey, and we ask them a series of questions around their experience that they had with us. And you can see that we have a 32% response rate, which is pretty high for any survey. And then that response rate goes through these sort of analytical tools using natural language processing and sentiment analysis, all of this artificial intelligence stuff. And coming out of that, you actually get analytical data that we can make decisions on. And one of the things we get is this thing called a Net Promoter Score, which is a tool derived from the retail sector. It's a management tool to gauge the loyalty, traditionally of customers, but in our case of donors. And a Net Promoter Score is the net of those who would promote your business and those who would send you negative messages and basically tell people to not come and do business with you. And it's a very well-utilized indicator in the retail sector, and we and other blood services are now applying this. And you can see that we have a target of 78 for a Net Promoter Score, which is actually a very high target. And in the early few months of doing this, our score is 84. Any donor who gives us feedback of 6 or less, in other words, they're pretty unhappy with the service they got from us, gets a personal intervention. If they've consented to being contacted, we contact every single one of them and follow up. And I think your team has done north of 2,000, if I'm not mistaken, follow-ups with unhappy donors. And the purpose is to try to understand what fell short in the experience and close that gap. So that's one body of work that we do that I think is very important. The other one, as the board knows, is we're trying to move more and more of our donors onto the digital platforms to take command and control of their own appointment environment using either our website or mobile apps or the donor concierge technology that we have inside our collection events. And you can see here we're trending in a very, very strong positive direction that by the end of this year, we expect more than 60% of all appointments to be booked through our digital channels. And this is very good. It simplifies the process. It provides greater satisfaction to donors. And it's frankly in line with modern methods for those of us who book our yoga sessions or our movie tickets online. You know, it's about time the blood sector got into the same day and age. So very good work there, and you can see as a consequence the use of the National Contact Center and in-center booking by people is going down. This is one of the data points I referenced at the outset. While we're continuing to meet customer hospital needs very well, we have had a bit of a challenge in growing the size of the donor base overall. And you can see that the donor base is about 16,500 smaller than we would like it to be and than it was last year. So some challenges in growing new first-time donors and reinstating lapsed donors. So we still have a robust donor base and we still have a high frequency commitment from our donors, and therefore we're more than able to collect the volumes of blood that we need. But we need to grow the size of the donor base, and we need to recruit new folk into the system on a continual basis. And so you can see we have a bit of a shortfall there. There are many programs and initiatives identified to try to understand the cause of that. I talked to the board yesterday about some of this being driven by the move out of sort of particular mobile collection environments into newer collection environments in the urban centers. And as we shift the network model, we need to make sure we're growing the donor base to support that network model. And I'm not going to go through all the data on this slide. These are just some of the initiatives that are in play to help drive up the size of the donor base. They tackle experience, they tackle diversity. I know this is an issue of high importance for all of us. And so how do we ensure we're reaching into the diverse communities of Canada? And they leverage technology to make sure we're attracting and retaining the sorts of donors that we need. One of the physical things we did and are in the process of doing slowly across the country is modernizing our collection centers. And if you've ever been into the Edmonton Blood Center, you would know that it was in dire need of a few light bulbs and a bit of modernization. And this was the first donor center of the future template, if you want. And it is a great donor center today. I was there not very long ago. The staff love it. The donors love it. It's always been a very, very high collecting center. It's one of our most productive, largest volume collecting sites, but really it was in desperate need of modernization. And so it was the first out the box, and we're doing that in other sites across the country. And one of the other things we're paying attention to on the donor world, very briefly, is the health of donors. So it's not only about a great experience, but it's making sure we're not harming our donors. And so you can see a pretzel and a bottle of juice here. And why we do that is because there is a lot of evidence in the medical literature that one of the ways to reduce the likelihoods of donors fainting, having so-called vasovagal reactions, is to ensure that they are well hydrated and had some salt before they make a donation. And so, we might all joke about salty snacks and hydration. It's actually a really important initiative, and Mindy and others in Israel's group have led a series of initiatives working with the supply chain to put in these processes to reduce the likelihood of donors having adverse reactions and to make sure that we treat our donors well and look after their health very carefully. Briefly on the donor front, I thought, Mr. Chair, I would just mention, mostly for the members of the public, we talked about this at the board already, around some of the work on the MSM criterion. It's a long story, as we all know. Criteria was most recently, the criteria were most recently changed in summer of this year. We now have a 3-month deferral policy. Just a few weeks ago in Toronto, we hosted a knowledge synthesis forum, bringing together all the researchers. There are 15 research projects underway in this country. This is all enabled by the funding we received, we and HEMA Quebec received from Health Canada, that has now enabled a body of research to occur that will inform the next body of evidence to further evolve the policy beyond what we have today. And this was a fantastic opportunity to hear the current status of those research projects and where that's all going. And one of the particular areas of work we're interested in, what can we do in Canada to allow some groups of MSM donors to potentially be plasma donors, even in advance of changing the policy that may exist for blood donors. So a lot of work there, and certainly a great call out to Health Canada for enabling a body of research in this country. The board knows well, you mentioned this in your opening remarks, Mel. I'm going to be brief here. We've announced our 3 sites, Sudbury, Lethbridge, Kelowna. Sudbury will be opening in the summer of next year, and then a staged opening of the other 2 sites, and a lot of work underway now. So I'm not doing it any justice, JP, but a lot of work underway now to get the collections model in place and to recruit the right donor base so we can collect the right volumes at an appropriate cost, meeting our needs going forward. And this is just some of the work we've shared with the board in the past on the approach to donor recruitment in our new plasma centers. I'm moving fairly quickly now, but just on the 4th key focus area about employees, making sure we create an exceptional experience for employees. Lots of work on what we call the moments that matter. These are identifying the life cycle events of an employee, from essentially recruitment right through to leaving the organization, and all of those moments that matter across the continuum, and making sure we have activities, programs, and data to support the life cycle of employees and improve their experience at Canadian Blood Services. We're modernizing the workplace. The board saw an example of that last time you were in this building, and lots of guidelines to modernize the way we do our work and where we do our work. Diversity is a very important part of that. We talk a lot about this at the board, obviously, and at management, making sure that we address both diversity and inclusion in the workplace, because frankly, it's only the right thing to do, and we have to have a workforce that reflects the diversity of Canada, and that's even more important when we're seeking to create and attract diversity in our donor populations. We have to make sure we have an organization that is reflective of that. So a lot of work there. I'm not going to go through the detail on this slide. You can see we sort of have a foundational approach, building up to a sustainability and community-focused approach. And 2 early examples were the creation inside CBS of 2 employee resource groups, LGBTQ+, and a Women in Leadership group that I asked Judy and Pauline to co-sponsor, and lots of very exciting uptake by women leaders in the organization, and equally true by individuals who have come forward and said they're willing to be part of an LGBTQ+ employee resource group, and they just do some really great stuff in the organization. There's some photos that the board saw of our workplace of the future. This is just a pilot as we seek to modernize where and how we do our work. I thought I would just mention briefly, but we're going to bring this back to the board next year as we evolve our thinking around corporate social responsibility. We have done little bits of this in the past, but we really haven't had a fully flushed out CSR strategy. And of course, this is again what all good organizations are doing. So we're in the building phase now of identifying what are the drivers for a CSR agenda at Canadian Blood Services. How do we position ourselves to be responsible ethically, environmentally, and all the other ways that underpin corporate social responsibility. And we will be bringing this back to the board in sometime next year as to what is the long-term CSR strategy for this organization. So we'll talk more about it there. We do track occupational health and safety data on a regular basis. It gets reported to the Talent Management Committee. Here are the data for the first 6 months of this fiscal year on one of the important indicators, the so-called injury frequency rate, and you can see it's consistently below 3.5%. And I just wanted to give the board a bit of a sense of the types of injuries. The two major categories in our operations are slips, trips, and falls. So an employee trips while either going up these stairs or in a manufacturing facility or while going to the parking lot and there's ice in the parking lot. And the other major category is manual handling, so the sorts of lifting boxes and moving things on trucks and what have you. So those are the two major categories, but overall pretty low measures and ones that we track on a constant basis. And the last key focus area is the area of advancing excellence across the organization. And I wanted to show you 2 or 3 data points. So continuous improvement is a major focus of the work we're doing. And this is just an example, and I'm not going to spend much time on it in the interests of time. But Rick has really instilled a culture of continuous improvement across all the sites, and it's linked very strongly to our quality management system and our LINK program. There's a very tight connection between quality management system, continuous improvement, and maturing all of those environments and the culture of excellence in the organization. And here are just some examples of frontline-driven initiatives, small changes. These are not big projects that need big investment. Small changes that have improved the work environment and made major operational improvements that have benefits both for employees as well as for product safety and ultimately cost as well. And those are just examples. There's a multitude of others we could have put up there. You all are aware that Calgary is nearing completion. We will be hosting the board meeting there in June. It's really beginning to look fantastic. It's a very, very well purpose-designed facility and is going to score very high, we believe. On the LEED certification, we are going to apply for gold LEED certification. And one of the many good examples you can see there. This is the single largest solar installation in southern Alberta, I believe, or in Calgary. We have over 700 solar panels on the roof that will provide 26% of the total energy needs of that facility when fully operational. And that's just one way of demonstrating our corporate social responsibility. This and the next slide are busy, and I'm not going to dwell on them, but the board knows that we measure our quality management system effectiveness in a variety of ways. We have specific quality indicators that look at the indicators within the processes and of the product quality, and we also measure the effectiveness of the overall quality management system. And I think it's fair to say with that slide and this one that the quality management system continues to mature, is in a state of control, and we continue to make movement appropriately along the spectrum of modernizing and maturing our quality management system to rival the best in the biologics industry. And again, briefly, one indicator in the key focus area of organizational excellence, and it's one where we benchmark ourselves against other blood operators around the world, is productivity. So how productive and efficient is our operating environment across 4 components of the supply chain: recruitment, collections, production, and testing. And you can see in all 4 components of the supply chain, over the last 5 years, we've had significant improvements in our productivity measures, as much as 80% in our testing productivity, and as the lowest is in collections, a 16% gain. So 2 important points. One is the rate of gain over the past 5 years is the highest amongst all ABO comparators. The less positive way of looking at that is we're on the lower end of the comparator group. So we've still got opportunity to work towards, and we know that, and we have many initiatives in place to do that. But I think the important evidence here is that all the work that we're doing is making the organization more productive. We talk about digital a lot, and the one way management tracks their commitment to a digital strategy is in this key focus area here. And again, just to show you some examples, whether in the donor space, the employee space, or our customer hospital space, these are some of the initiatives that are underway in terms of using digital capabilities. And I mentioned at the very outset, what seems like a long time ago, work we're doing with our hospitals for online ordering capabilities, and a couple of pilot projects that are underway in both Newfoundland and British Columbia in that regard. So just some examples of our migration towards a digital organization. And Mr. Chair, I'll close with just 3 or 4 very important slides on the financial health of the organization. Obviously, this is dealt with in much more detail at the Finance and Audit Committee, but I want to just sort of, for the purposes of a full presentation to the board and also for members of the public, give a sense of the financial health in the first 6 months of the fiscal. So on this slide, you sort of see the high-level summary of the financial health of the organization for the first 2 quarters of 1920. And of course, working capital is made up of multiple components: unrestricted cash, organization's receivables, the total inventory, and the prepaids minus our accounts payable. And so I just want to speak to 2 or 3 important messages on this slide. So one is the key takeaway is the organization is in a very strong financial position. We have, as you can see there, $213 million in working capital. Our unrestricted or unreserved cash has come down from year-end, March 2019, to September 2019, but it is still in a very positive place. And we're very well within the policy guidelines of days of cash on hand to meet all the operating requirements of the organization. And we're currently at 36 days cash on hand with a policy parameter of 15 to 45 days. It is important to point out, because we often point it in the opposite direction. So if you look under the receivables group, you can see our receivables have come down by $16 million from year-end, $31 million to $15 million. And that is very much in large part to Ontario paying its 2018-19 commitment in full, and so that significantly reduced our receivables, which the board might recall had been in a much worse position in prior years. The inventory number is a complicated number. It's sort of similar to year-end, $140 million, but there's a lot of ups and downs in that. There's some inventory is significantly lower than at year-end, some is higher, and it's really driven by the different price and mix of products that are in inventory. Most of that is plasma protein products, but not all. And on the plasma protein products, overall, we have about 7.5 weeks of product inventory in hand, which is marginally higher than our target of 7 weeks on hand. So overall, a very good financial position. The captive insurance company, Canadian Blood Services Insurance, Inc., shown on this slide here. 2 important data points. If you look at the big green bar, that is the total assets in the investment portfolio, and you can see that it's gone up from year-end by an additional $7 million, 475 to 482. So the total portfolio is in a very positive place, currently having about a 7.5% annualized return calculated on a fair value basis. So the portfolio continues to do well and track against benchmarks. The light green bar shows a significant reduction in the so-called premium net assets. This is the available funds within the portfolio once all the obligations of insurance policies, statutory reserves, market volatility reserves have all been accounted for. There are assets in the portfolio above and beyond all of those liabilities. And you can see it was $107 million at year end, and it's now at 63. And the reason for that is we made a very important policy decision both at this board and at the CBSI board to increase the size of the primary policy limit in CBSI from $250 million to $300 million and reduce the government indemnity in the second captive CBSE from $750 million to $700 million. So this is a very important and very good news story in terms of now having $300 million set aside as a provision for future claims, and certainly reduces the liability that governments have through the secondary captive CBSE. So a good financial position and a healthy portfolio at CBSI. And lastly, just on an expenditure point of view here, if you compare this time period to the same time period last year, so our expenditures look like they've gone up, but really, if you take out of the calculation that $50 million insurance provision increase, so this is a non-cash item on the statement, but if you take that out, you can see that our cost of plasma protein products have actually gone down by $12 million compared to the same time period last year. And there've been a slight increase in expenses across the rest of the operation, driven by pension costs and staffing costs for NFRP2 and a variety of other small items, but a net reduction in expenses from $589 million down to $582, which then nets out the $50 million that is shown there for the insurance provision increase. And what is that $12 million in plasma products made up of? It's again some ins and outs if you want. If you look at the first three bars, the overall use of the product continues to drive up costs. So you can see in the immune globulin category and the C1 esterase inhibitor category, about $19 million more product used than the same time period last year. But we've had some very significant gains in the price and mix impacts across the rest of the portfolio, driven by some lower prices of products for hemophilia care and some other products that we've been able to bring onto the formulary at lower prices. So you can see there's a positive gain in the price and mix, offset by some increased utilization compared to the same time period last year, for an overall positive period year over year of $12 million. And Mr. Chair, you mentioned this in your remarks, so just to close on an important governance point of view, the National Accountability Agreement is signed as far as CBS is concerned, and hopefully the jurisdiction will be able to sign it in the next few weeks. The collaborative performance review is getting underway, I think is probably the best way of saying this. The scope of this review will be 7 years, April 2012 to March 2019, looking at fresh blood components and plasma protein products, looking at 4 main activities: our quality management system, risk management system, our productivity and efficiency program, and organizational governance. And it will do a bit of a deep dive into our automated supply chain and donor experience initiatives. This is a review that is done collaboratively with the provinces. It should be beginning imminently, hopefully in the early calendar new year, and we aim to have it done by the end of the fiscal year. So that's a very aggressive timeline. So I'll close, Mr. Chair, by sort of repeating a few themes. Strong operational performance across all product lines. Not perfect. We've got some challenges, for example, on donor recruitment for first-time donors. Patient needs being met on a consistent basis across all product lines. I talked about some operational challenges. We're going to talk about the challenges with plasma protein product inventory and brand diversity and what have you later on this morning. The enterprise risk program is robust and in a state of control. No emerging safety threats that are not within our scope of monitoring and surveillance. The strategy is well underway in terms of execution, and I believe from a governance point of view, Canadian Blood Services is in a good place.
Thank you, Graham. Any last questions or comments from the board? Look, that was a great tour d'horizon, and I think we are indeed in good shape. I think that none of that removes the importance of vigilance for you and your EMT and for us as the board. So, but nevertheless, well done. I now call it 10:15, and we had planned for a coffee break. Let's come back in 15 minutes at about 10 to 11, and there's coffee and muffins in the cafeteria. Thanks.